Today's lecture covers the renal and urinary tract, kidneys, and the urinary tract. And this, again, is a single lecture topic. So there will be a quiz covering this particular lecture by itself. This should be review, but I want to make sure that you're comfortable with remembering how the kidney works basically. This should have been covered in anatomy and physiology, but it may have been a while for some of you, so let's do an overview. Cardiac output goes down the aorta, goes out the renal arteries to the kidneys. 20% of your blood goes directly to the kidneys to be filtered. That means a fifth of your blood gets filtered every time it goes out. Therefore, about every 5 minutes, your blood is completely filtered. This is one reason it's difficult to have really perfectly successful urinalysis. Dialysis, because you go to dialysis but you can't be there every 5 minutes. You get your blood cleaned, and then you spend a couple of days having the acids and pollutants and whatever build back up again. So it goes into for filtering. It goes out the renal arteries. It goes through a series of smaller arteries. The arcuate artery is the one that goes into the glomerulus, produces the glomerular capillaries, which have high pressure and therefore filter a lot of fluid out. That fluid goes into Bowman's capsule, where it goes through the tubule, down the loop of Henle, up the loop of Henle, then through the distal tubule into the collecting duct. As it goes through there, it picks back up the things that you want to keep. So you filter a lot of fluid out, and then that fluid goes through the kidney, through the tubule, and these glomerular capillaries send another set of capillaries down past the tubule so you can reabsorb the things that you want, and the rest of it gets peed out. Most substances are freely filtered. That means if 20% of the blood gets filtered, 20% of the glucose goes in, 20% of your amino acids go in, 20% of your sodium. It's the same concentration it is in the blood. Some things are not freely filtered because they're too big mostly. Large proteins, plasma proteins, red blood cells, they don't get filtered into the pee, so they don't have to be reabsorbed. Most of the reabsorption of the things you want to keep back out of that filtrate occurs in the proximal tubule. Very soon you take back most of it, and then the rest of the time you're kind of fine-tuning how much sodium, how much potassium, how much fluid you want to keep, and then how much you pee out. Descending limb mostly absorbs water. Ascending limb absorbs electrolytes. The collecting duct then is a true fine tuner, the distal tubule and collecting duct, and they respond to aldosterone and antidiuretic hormone in deciding which or how much water will be reabsorbed finally to concentrate that urine, so that you pee out only what you need to pee out and you retain the rest. Any extra solute in the urine increases urine output. Because it has osmotic pressure, it will pull additional fluid into your pee. That's how diabetes works. The diabetes mellitus, the extra glucose in the sugar provides osmotic force that pulls excess water and you pee too much. You should reabsorb all of your nutrients. So things like glucose, proteins, and also blood and bacteria should not be found in the urine. If you do a urinalysis and you find glycosuria, proteinuria, hematuria, then you have some kind of a problem. Kidneys control their own blood flow. They secrete vasoconstrictors and vasodilators at the incoming and outgoing arterioles to make sure that the right amount of fluid goes through the kidney. And if that is thrown off, then you make too much urine or you make too little urine. They will control electrolyte balance and acid-base balance by either retaining or peeing out sodium, potassium, also hydrogen ions, bicarbonate to control acid-base. They control your overall osmolarity of your blood. If your blood is too thick, you secrete antidiuretic hormone and your kidneys retain pure water, and it thins your blood out. It increases the blood volume, but it doesn't add solute, it just adds fluid and therefore thins it out. Kidneys control your blood pressure that way, and also with aldosterone, which at the collecting ducts causes you to retain sodium and thus retain water by osmosis, and your blood volume and blood pressure goes up. This is that renin-angiotensin-aldosterone system that you probably heard about plenty. Kidneys also secrete erythropoietin when oxygen levels are detected that are too low, meaning that you don't have enough oxygen carried in your blood, so your kidneys release erythropoietin. It causes your bone marrow to make more red blood cells. It's why people go to high altitude to train. Hypoxia causes you to release erythropoietin, and you make more red blood cells, and it makes you run better. Kidneys activate vitamin D. Vitamin D is required for absorption of calcium at the gut. The glomerular filtration rate is the rate at which that blood that's going through is actually producing urine. How many milliliters per minute or how many milliliters per hour is being produced. It's a good indication that your kidneys are working okay. Should be around about 125 milliliters per minute of fluid is produced. Now you reabsorb most of that, otherwise you'd pee out your blood volume in a very short time. But you're producing it in the first place, should be around 125 mLs per minute. And the term renal clearance refers to how quickly your blood is being cleared of a substance. How much blood is getting cleared per minute of a particular substance. So if you take penicillin and the renal clearance rate is a certain rate, it means that you're clearing it from your blood, peeing it out, and therefore you need to take another tablet, at X amount of time, otherwise your concentrations get too low. Anatomy, the renal cortex, the renal medulla, which has these pyramid-shaped things in it. You have your nephrons. You have cortical nephrons and medullary nephrons. They do the same thing, except these guys are longer and these guys are shorter so that they fit in where they're supposed to fit. These nephrons dump into the renal pelvis here, which is the collecting area for all of the urine that's been produced. The renal hilus is this bent-in point that has the renal pelvis in it and all the blood vessels and things going in and out of it. And so you have blood coming in, you have blood going out, and whatever got filtered out goes into the ureter. From the renal pelvis, it goes into the ureter to be peed out. The functional unit in the kidney is the nephron. Blood comes into the glomerulus. The glomerular capillaries are here. You filter out your primary pee. It goes through the proximal tubule, convoluted and straight, descending loop of Henle, ascending loop of Henle. the distal convoluted tubule, and the collecting duct. And this is where all of these things happen. Filtration happens here, then you start reabsorbing back into these peritubular capillaries so that the things that you filtered out that you want to keep come back into the bloodstream. What you don't want to keep gets peed out. The organs themselves, the structure, the kidneys, renal and nephro. Reno and nephro are the two terms. So you can have renal disease, you can have nephritis, or something, if you have inflammation. The ureters are the tubes that transport the urine from the kidneys to the bladder. The bladder stores until it gets to a certain point, and then it can't hold anymore. And then it has a muscle on the outside, the detrusor muscle, that squeezes, and it has a sphincter that opens. So you have to squeeze the detrusor and relax the sphincter, or open the sphincter, to allow urination to take place. Like defecation, we have an internal and external urinary sphincter. The internal one is involuntary. It opens when it's time to pee. The external one is the one you get to control. The urethra then takes the urine from the bladder outside the body. Here we have the abdominal aorta coming down, the renal arteries, renal veins coming back, the ureters going down to the bladder. The bladder is in the pelvic cavity. The kidneys are in the abdominal cavity, but they're on the very back behind the peritoneum. They're retroperitoneal. So, the pathology of it is, what can go wrong here? Well, first of all, you can obstruct in a variety of ways. You can have a stricture or a stenosis of a tube that could be congenital. It could be caused by inflammation or infection. It could be blocked by a kidney stone that moves down and blocks a tube. So you can have a urinary tract obstruction. It keeps the urine from moving. Pressure backs up and causes all kinds of problems. Obstructive uropathy means you've got a blockage causing disease in the urinary tract. And it can be everything from severe to mild, depending on how bad it is and whether it's only one side or both sides. Here we have an obstruction, a stenosis down here that's causing a backup. Here you have a band of tissue that is wrapped around this one. It's like an umbilical cord around a kid's neck and has blocked it off. So there are things that could block it off, and you back up pressure in here because you're constantly making fluid, and now it's got nowhere to go. You can have the prostate blocking here. You can have a valve problem where it won't open properly in the internal-external sphincter. Here we have a hydroureter, means extra water in the ureter. The ureter is supposed to be about the size of a thick spaghetti noodle. And here, it's all backed up with water, and then you have hydronephrosis, where it has filled up the kidney with water, and it's causing it to expand too. We'll talk about things like polycystic kidney disease later. Although, the fact that you have polycystic kidney disease means you have blockages inside the kidney, which can cause constriction of flow as well. Kidney stones are a good way to block things off. They're called renal calculi. I always think calculus is hard, so a renal calculus is a kidney stone. The term is nephrolithiasis. That's another term for stone, that monolith stone. So a condition of stone in the kidney, nephrolithiasis. They're formed of crystals of a variety of sources: calcium, uric acid crystals. And depending on how big they are, they can be a minor irritant to the most painful, difficult thing you've ever experienced. Risk factors: here's some kidney stones of various shapes and sizes. Men are more likely to get them than women, although postmenopausal women start to catch up. Family history: it is somewhat genetically predisposed. Caucasians are more likely. Geographic and seasonal factors may be because of activity levels and the amount that you drink, how dehydrated you get. Being dehydrated is a way to encourage kidney stones because the concentrated fluids precipitate out solids more easily. Fluid intake: low fluid intakes concentrate the urine too much. Super high protein increases a variety of products that precipitate out and cause kidney stones, and insulin resistance that goes with diabetes. So these are some of the things that make people more likely to get them. Supersaturation of something: if you put too much sugar in your tea, it won't all dissolve. Some of it falls out. Some of it precipitates out. So either you have too much solute or too little fluid, and that's a good start toward getting kidney stones. If your pH is abnormal, if you're too acid or too base, the right amount of acid keeps things in solution. Too much acid causes uric acid stones to develop. These are less common. Too alkaline, though, which is actually a more common problem, allows the calcium to come out of solution. Acid keeps calcium dissolved. So if your urine becomes too alkaline, you're predisposed to having the calcium formation of kidney stones. Furthermore, our kidneys make substances that are supposed to help keep crystals in solution. If you have a deficiency in the crystal inhibitors, you can form kidney stones. And that's probably where the genetic predisposition or the family history comes in. If you have that inability to produce enough of those anti-crystal substances. Calcium is the most common producer. Uric acid: somebody who has high uric acid. Gout: people with gout are more likely to get kidney stones of that type. Remember, calcium hypercalcemia will predispose you to kidney stones. Now, that doesn't mean that taking a calcium supplement when you're old will give you kidney stones. Because if you take the calcium and your parathyroid hormone puts it into the bones where it belongs, you don't wind up with high calcium levels in your blood, and therefore you're not predisposed to kidney stones. It has to be in the blood for it to be a problem, and so anything that causes hypercalcemia, like if you have hyperparathyroidism, parathyroid hormone takes calcium out of the bones and puts it in your blood, that kind of hypercalcemia would predispose you to calcium kidney stones. Pain, sometimes severe that women say it's worse than childbirth. Bad enough to cause nausea, vomiting sometimes. And if you change position, it doesn't help. If you have gas pains or something, a lot of times you can find a comfortable position. Kidney stones don't get better when you move around. Intravenous pyelogram, that means that you put a contrast medium into the blood, and then as it goes through the kidney, you take images of it and it shines where it's going, and it'll show if there's a blockage because it stops going there. Or you can do an image, an X-ray type image, CT scan or something. The kidney, ureter, and bladder, usually are x-rayed together or imaged together, so it's called a KUB test. Treatment: drink a lot of fluid, take some painkillers, and if it's a really small kidney stone, wait for it to pass. And it'll pop out eventually, usually. If you're eating too much meat or whatever that's helping to form the kidney stones, cut back on that. And lithotripsy, tripsy means to break apart. Litho, again, is a stone. And so it's using an ultrasound kind of shock waves to break up the kidney stone so it's small enough that the pieces can be peed out. Lower tract obstruction can come in a couple of ways. You can actually have a stone that goes farther down, blocking. It can get into the bladder and actually block the outflow from the bladder. But a lot of times this is more of a neurogenic problem where you can't cause the detrusor to squeeze, or it squeezes too much, or the sphincter won't open, or it won't close, or it can't open because the prostate is squashing it. If you have BPH, benign prostatic hyperplasia. So overactive bladder syndrome, you're constantly stimulating the bladder. It always wants to pee. Urgency, always feel like you need to pee. You need to pee at night. Hyperreflexia, too much. Hyporeflexia or areflexia is underactive. Now, the kidney is considered to be a gland, so adon is the term for a gland, and oma is a tumor. So adenoma, renal adenoma, is a tumor of the renal gland. It's benign glandular tumors. Now, just because they're benign doesn't mean they can't ruin your kidney. It just means they're not cancerous. Or you can have cancer cells, kidney cancer, which is a pretty serious one, and kind of along the lines of lung cancer or pancreatic cancer. Maybe not quite as dramatic, but not pretty bad. Transitional cells, this is kind of an epithelium that goes around things that can stretch and contract and transition in size and stuff. And these are the most common cells to become cancerous and grow into cancerous tumors. Males over 60 and smokers most likely to get kidney cancer. A UTI, urinary tract infection, obviously quite common. More common in women than men. Their urethra is so short and it's close to the vaginal and anal and urethral openings, and everything are right next to each other, and therefore it's easy for bacteria to make its way up into the urinary tract, the bladder, and so forth. Usually it's a bacterial infection. A lot of times it's E. coli, because feces is full of E. coli, and improper cleaning down there or wiping in the wrong direction will tend to introduce E. coli into the opening of the urethra. Cystitis means bladder. Any fluid-filled thing is either a cyst or a vesicle. So vesiculo is the bladder, and so is cysto. So cystitis is a bladder infection or bladder inflammation. It can be quite painful. It can sort of itch and make you feel like you need to pee all the time. And if it goes farther up, it can inflame the ureters, ureteritis, or the kidneys and the kidney pelvis. Pyelonephritis is the kidney and kidney pelvis being inflamed. Cystitis, got to pee all the time, it hurts, burns more than hurts, feel like you've got to go really bad, and sometimes pain, especially if you can't clear it out. And you take antimicrobials, usually antibiotics, more fluids to flush it out. And there are some analgesics that you can take that just simply cause it to burn and hurt less. There is a cystitis that is, it's not that common, but it's more common to women than it is to men, that has nothing to do with a bladder infection. Just a inflammation of the bladder and urinary tract for unknown causes. It's hard to treat it. It comes and goes on its own. Pyelonephritis is the kidney and the kidney pelvis. So the kidney is here, the pelvis is here, a lot of inflammation moving from the kidney into the renal pelvis. Acute, if you got an infection that made it all the way up there, you have acute kidney pain. Again, vesico-ureteral reflux. In other words, it's backing up out of your bladder. If you have BPH bad enough that your bladder is overfilled all the time, the pressure can push stuff back up into your kidneys. It can cause enlargement of the ureter. It can cause a backup that can enlarge the kidney. Or if there's any bacteria there, the bacteria will be pushed up in the direction of the kidney too. E. coli is another big player here. Chronic pyelonephritis can be caused by a number of conditions, from autoimmune to bacterial infections to other types of like obstructive kidney disease problems that cause it to stay inflamed all the time, and it hurts all the time then, and damages the kidneys over the long run. Pyelonephritis, enlarged, causing nephromegaly, an enlarged kidney that has been inflamed and swollen. Glomerulonephritis. Now this is the glomerular and nephron, stuff themselves, the actual little areas. And this can happen if you have an attack on or a disease of the actual filtering mechanism. Immunologic abnormalities, your inability to fight pathogens, or autoimmune attack of your own cells. Some drugs and toxins will inflame the filters in the kidney. Glomerulonephritis in general produces two, besides the pain, the urgency of urination and the like, produces two major signs, and that's blood in the pee, protein in the pee. Hematuria, proteinuria. Oliguria is not enough or scanty urine, so you're peeing less and less and less. Hypertension, because you're not getting rid of the fluid, it's staying in, and so your blood volume increases. And edema in especially peripheral hands and feet from the hypertension, which is now pushing fluid out of the capillaries into the interstitial fluid. Glomerulonephritis. You just are not making enough urine because the glomerular filtration things themselves aren't working right. You're not making the urine, therefore it's backing up, and the inflammation in the kidney can be seen right here. Nephrotic syndrome can be caused by any of these things. Nephrotic syndrome is when your kidneys aren't working right. And so a syndrome isn't a disease, it's a series of signs and symptoms. It could be caused by glomerulonephritis, it can be caused by pyelonephritis, it can be caused by polycystic kidney disease. And what happens is your kidneys don't work as well. It changes the volume of your urine. But one of the main things is if you have a damage to these filtration mechanisms in the kidney, remember when you filter out 20% of everything, you're supposed to take back all the proteins and all the amino acids and all the glucose, and none of that's supposed to be in your pee. If the kidneys are damaged so that they're not functioning properly, stuff will start showing up in your pee that's not supposed to be there. Proteinuria. If you start seeing your plasma proteins are showing up in your pee, that's bad. So then you don't have enough plasma proteins in your blood because you keep peeing them out. You can't make them fast enough to keep your levels of plasma proteins up, to keep the osmotic pressure where it's supposed to be, to keep the fluid inside your blood vessels instead of allowing too much of it to go out, which means you wind up with edema, you wind up with low protein in the blood, and you wind up with excess protein in the urine. And we could wind up with vitamin D and therefore calcium deficiency because the kidneys activate vitamin D. And so if they're not working, that's going to be compromised as well. Acute kidney injury happens when you get a disease, a backup that is sudden and stretches the kidney to the point where it damages it. You get hit in the back by somebody's football helmet when you're playing football, or fall off your bike and land on your back. I mean, there are a number of ways that you can damage the kidney, and it will cause renal deficiency or renal failure that is often temporary. It can heal, but for a while you will be in some kind of renal failure. If it becomes extensive, it can be irreversible. Like if you get hit so hard, I've had a friend who got bucked off her horse and landed in such a way that it damaged the kidney so badly that they almost had to remove her kidney. It did finally recover, and it's at about half function right now, but at least she didn't have to have it taken out. Renal insufficiency if it's down a little. Renal failure if it's persistent and down a significant amount. End-stage renal failure, you've got to have something done with the kidney. Or you might, if it's not necrotizing and going to die and cause infection, you can probably just live off the other one. A pre-renal problem is the inflow to the kidney is blocked or somehow compromised. GFR, filtration rate declines because you have less blood to filter. Intrarenal is a problem inside the kidney itself. So the blood vessels inside the kidney or inside the glomerulus, the glomerular capillary beds or whatever are damaged or diseased. Post-renal problems are the outflow, the renal pelvis, the ureters, the bladder, obstructions generally. So here we have lack of blood flow to the kidney, or some toxic substance that damages them, or autoimmune attack of them, or whatever. Tubular necrosis, damage to the tubules, injury to the glomeruli, winds up with a decrease in urine production, obstruction, decreased GFR, so not enough pee, and the leak back or push back increases pressure back into the kidney, which makes it worse. So it becomes a cyclical problem that can get worse and worse. Acute kidney injury, it first gets damaged, GFR drops a lot. If it can recover, then it will remain an acute problem that got better. The maintenance phase, the kidney has stopped getting worse. It's functioning at a somewhat lower level, but there is some kidney function going on and recovery is taking place. Urine output is low right now, and the creatinine and blood nitrogen, these are things you're supposed to pee out, start building up in your blood. And the recovery phase is if you actually heal the tissue, get most of it back, mostly normal renal function is reestablished, and you pee like mad because you haven't been able to pee in a while. You haven't made enough urine for a while, and therefore increase in or diuresis, increased peeing, and the creatinine clearance is increased, so the creatinine levels in your blood drop while you pee out more creatinine. Creatinine is a great substance for determining how well your kidneys are filtering your blood, because creatinine is a substance you make with muscle activity, and you want to get rid of all of it because you're always making more, so your kidneys get rid of all the creatinine that goes through the kidney each time it comes through. And therefore, by measuring how much is in the pee and how much is in the blood, you can tell if it's making the right amount of clearance, if the clearance of it is what it's supposed to be to maintain. So that's why it's building up here and it's going back down here. Chronic kidney disease happens for a variety of reasons. Kidney disease like polycystic kidney disease, long-time damage to the kidney that scarred it so much that it doesn't have the ability to produce urine much anymore, drugs, chronic alcoholism, massive amounts of ibuprofen or Tylenol, or sometimes, but massive amounts can do kidney damage. Hypertension, because you're not producing the pee. Diabetes causes bad vasculature everywhere, damages the kidneys as well. Intrinsic kidney disease, such as polycystic, which we'll see. And kidney disease results in kidney failure that has some different levels and different stages, kind of like as you approach or you lose bone mass. You have osteopenia, and then you have osteoporosis. So normal is about, 125 milliliters per minute is normal GFR, or average. And if you drop down to about 90 to 125 is still in the normal range. You get below that, and you're in mild kidney failure. Below that, it's moderate. You start thinking about below about 30, and you're in really serious kidney failure, and end stage is 15. That's a good number to remember. If you're in end-stage renal failure, you need dialysis. You need, blood pressure controllers. If you're not producing that much urine, you're not filtering your blood enough, and it's going to be lethal. Old people, as you age, you get decrease in the number of muscle cells in your legs. Even if you're lifting weights, you slow it down a lot, but they decrease in number. You also, in the kidneys, you decrease the number of nephrons over time. And by the time you're 80, almost everybody's down around 60, 65. So you're in mild renal failure just because you're old. My mom is 96, and she just went for her physical, and she's still, super active and doing quite well, and her GFR was 64, I think. So for 96, that's not bad. Kidney disease starts out with some kind of injury, loss of nephrons, the loss of proteins, so the protein is showing up in the pee. You damage the kidney, so you start developing fibrosis and scarring. And because you're not producing the urine, the hypertension increases the pressure back at the beginning, and it becomes that cyclical problem where the worse your kidneys get, the more your blood pressure is affected, and that blood pressure affects your kidneys, and that makes them worse, and so forth and so forth. Proteins in the urine, creatinine buildup in the blood because you're not peeing it out like you should. Fluid, electrolyte balance, and acid-base balance are badly affected. Sodium and water balance is screwed up because in the collecting ducts, where you have your ability to respond to hormones like aldosterone, which makes you retain sodium, you retain water along with it. If that is messed up and you either retain too much sodium or not enough, then that's going to cause a balance of sodium shift and also a blood volume shift. And the way you retain sodium in response to aldosterone is you run sodium potassium ATPase pumps faster, so it pumps more sodium back into the blood, so you retain sodium, but it pumps potassium the other way, so you become hypokalemic at the same time you become hypernatremic. So if sodium goes up, potassium goes down. If sodium goes down, potassium goes up, because they're driven in opposite directions by these sodium-potassium pumps. Therefore, sodium and potassium balance will be off in opposite directions. Lack of vitamin D activation, so you can have bone loss, bone fractures. Acid-base balance, metabolic acidosis. If you can't pee out your acids, if you can't filter out the hydrogen ions and pee them out, and you retain too much, you're going to have a metabolic acidosis. You can compensate some by breathing harder to blow off CO2, but it's going to throw off your acid-base balance. Renal failure, lethargy, then seizures, and then coma, and then death. Kidney failure is lethal beyond a certain point. If it's long-term, mild to moderate kidney failure, it will produce hypertension, which causes heart problems, heart failure. It may cause amenorrhea or impotence, change your pigmentation, change your ability to, your blood is becoming toxic to your own body because you're not filtering out what needs to be filtered out. You're not maintaining a balance on any of the blood constituents that are supposed to supply your tissues. Multiple organ failure ultimately, and I mean, you don't die because the kidneys failed. You die because your heart stops or your liver fails or something, but it was because the kidneys failed first. All right, so let's look at some kidney problems that kids can have, and as usual, these are congenital, things that kids tend to be born with for the most part. A couple of congenital problems that can happen with virtually anything, any structure in a child. You can be born with something outside your body, like the bladder. You know, you can be born with your intestines entirely outside your body, and they have to cut and put them in. The bladder entirely outside the body, and they have to put them in. Exstrophy of the bladder. Horseshoe kidney is when a kid is born with the kidneys combined. It's not always terribly serious. I mean, if they are working okay that way, it may be all right, but it's not perfect. Hypospadias and epispadias are urinary tract abnormalities where a male child is born with the urethral opening either on the bottom or the top of the penis instead of the end. It can be surgically corrected. If you look at the developmental phases of the fetal genitalia, when you start out, everybody's the same. You got a big hole here. You have, some tissue here, erectile tissue that will either become the head of the penis or become the clitoris. And the gonads are still way up in the body. They're going to have to drop down if you decide to form a scrotum because you're a male. And so depending on the hormonal output that you experience, you will start developing in the direction of the male or the female. But you can see this hole right here, that on a male, it closes up and leaves only the very tip of it open. On the female, it stays closed here and opens here. You can see how it would be kind of easy to have a developmental problem where the hole wound up in the wrong place. And hypospadias is more common than epispadias because this is where the hole is actually embryologically present that has to seal up. Bladder obstructions are not that uncommon. You know, we've seen some atresias of the esophagus. We've seen anal atresias. We've seen places where things aren't open, where they're too constricted, pyloric strictures or stenosis in the newborn. And so if you have an obstruction that is there from birth, it will likely have to be surgically corrected rather quickly. You can have a hypo or dysplastic development of the kidney. Horseshoe kidney would be dysplasia. It was developed wrong, but it could either develop not enough or develop in a way that the flow isn't appropriate. Aplasia doesn't grow, dysplasia. And polycystic kidney disease can happen to anybody. It can happen to kids too. Here we have polycystic kidney disease. A cyst is a fluid-filled space. Well, you sure got some here. Look at the size of this kidney. Polycystic kidneys can get this big. They obviously have to be removed. And a kidney transplant or permanent dialysis or something, this kidney is not going to function really. especially since this one's lying on a table right next to a football. Glomerulonephritis in kids, especially after strep throat, strep infections, skin infections, can make it to the kidney and cause an infection inside the kidney. Nephrotic syndrome, damage to the kidneys or insufficient kidney function from lack of development. Hemolytic uremic syndrome, the most common cause of renal failure in newborns and young children. If you have a condition or infection that causes your red blood cells to break down too fast, hemolysis, then as you filter the blood through the kidney, those pieces of broken red blood cell clog up the tubules and actually block the kidney from doing its job. Glomerulonephritis, sometimes purpura. Purpura means bruise. I always remember that because purpura sounds like purple. So nephritis, and this is an inflammatory problem, anaphylactic. It's like an allergic or immune attack response where your immunoglobulins are malfunctioning, causing inflammation to the blood vessels themselves. And kids have a lot of urinary tract infections, especially young girls. Young girls need to be taught very carefully to wipe front to back so as not to pull even a trace of feces forward into the urethra where it can cause a urinary tract infection. Cystitis and then pyelonephritis if it moves up past the bladder into the kidneys. E. coli. And if there's any blockage at all, could be from a urinary tract infection causing things to swell kind of shut, could be because of a congenital abnormality, could be because of the way the ureters are placed on the bladder that doesn't let them empty properly. Then you have a reflux that's backing up into the ureters, backing up toward the kidneys, causing swelling, inflammation, high pressure, maybe damage to the kidneys. Here we have, in this case, a congenital abnormality of the way the ureters come in. So they're supposed to come in kind of around the back and underneath. This is supposed to be the renal pelvis here, so this is taking the urine here. It's supposed to come back behind and kind of up underneath so that you have a trigone, a triple hole in the bottom where you have two ureters coming in and then the urethra going out. And if they're in the wrong place, they don't allow the bladder to function properly. Perhaps the squeezing of the bladder winds up pushing too much fluid back up in the ureter. A couple of tumors and cancers are possible. Cancerous tumor, Wilms tumor. Stem cells, when they're growing. Remember, a lot of fetal cells are very stem cell-like. They're having to create tissues from scratch, and they proliferate very quickly, and they differentiate, and in this case become cancerous and cause the kidney to enlarge. Nephroblastoma. Remember, we have a retinoblastoma. It's a cancer of the retina. And the term enuresis means peeing when you don't want to. Incontinence is another way of putting it. You can't control your urination, so therefore you suffer enuresis. You suffer the peeing when you don't want to. Now, really young people and really old people have this problem. Really old people, it's a structural problem usually. Their sphincters aren't powerful enough to keep them from peeing anymore. Their bladder is not as stretchy as it used to be, so it doesn't hold as much as it used to. And so incontinence among the elderly is quite common, and they might have to wear Depends or something like that. But kids, interestingly, when a baby is first born, it actually has an inhibition of the external urinary sphincter. That means that it can't control its peeing. When the internal sphincter opens, the external sphincter opens and the kid pees. And so it wets on itself all the time and you have to change diapers and stuff. It's not the baby's fault. It's not that they haven't learned how to use a toilet. It's that they can't actually control it. Now when it gets a little bit later, even some kids stop that by the time they're 2 or 3, but certainly by 4 or 5, if they haven't been able to control their urination and are peeing on themselves all the time, then it's a problem. It's actually enuresis. It's incontinence or enuresis in the baby. Primary enuresis means that they never did gain control of their urinary processes. Secondary means that they were doing okay for a while, but now for some reason they're not. Very likely they have a urinary tract infection or something going on that has changed it so that they can't control it like they used to. Daytime enuresis is wetting your pants when you're running across the playground, and nighttime is bedwetting. Defective parts, you don't have a sphincter that actually does work right. Something that might make you make urine too fast. Haven't developed the ability to control yet because the parts, they're not defective. They just, even at age 4, you still have that inhibition that prevents you from controlling it because you haven't developed that far yet, but you will. Genetic factors, which probably would be defective, talking defective parts. And of course, psychosocial, kids who are abused or who are afraid all the time or something are a little bit more likely or somewhat more likely to be bedwetters. Renal system.